So I'll start the session by discussing T-cell lymphoma. And, So as you all know, peripheral T-cell lymphoma are a group of very uncommon, heterogeneous non-Hodgkin's lymphoma that's affecting mature T and K cells. And it comprises a small proportion of non-Hodgkin's lymphoma in Western countries, about 5 to 10%, and with the most common subtype affecting the PTCL, not otherwise specified, angioimmunoblastic, and anaplastic large cell lymphoma. In contrast, the incidence seems to be a bit higher in Asia and perhaps South America as well. And as you can see here, PTCL NOS remains to be the most predominant subtype. However, the other two prevalent subtypes are the extranodal NKT cell and ATLL. Those are two virally associated subtypes, which seems to parallel with the geographic disease prevalence of the EBV and HTLV1 infection. And the 208 WHO classifications essentially group the mature T-cell lymphoma into 4 disease categories based on clinical features. For the discussion this afternoon, we're going to be focusing just on the systemic nodal and extranodal disease. And with the most prevalent subtype we already mentioned, those were PTCL, angioimmunoblastic, and anaplastic large cell. The International Prognostic Index, IPI score, remains to be the most robust prognosticator in T-cell lymphoma, similar to B-cell lymphoma. Over the years, a number of alternative prognostic index has been constructed, studied, to see if that would provide more T-cell specific information. However, none of them seems to have gained meaningful clinical use. I just include one of them as example here for your information. It's known as the PIT score prognostic index for peripheral T-cell lymphoma, where the extranodal status and also staging, Ann Arbor staging, was replaced by bone marrow involvement. So in contrast to B-cell non-Hodgkin's lymphoma, the clinical outcome for PTCL remains to be rather poor. With the exception of ALK-positive anaplastic large cell lymphoma, the T-cell lymphoma category, essentially has inferior survival outcome across the board. For example, the most common PTCL NOS and angioimmunoblastic subtypes has long-term survival of just about 30% with conventional chemotherapy alone, and some other rare subtypes, including the ATLL, extranodal NKT cell, enteropathy type, hepatosplenic subtypes, seems to fare even worse. And again, IPI score seems to differentiate clinical outcome with obviously higher IPI correlate with worse clinical outcome. So the management paradigm in T-cell lymphoma models after the B-cell, which sort of makes sense because majority of the study was conducted in B-cell lymphoma, which are the most prevalent disease subtypes. So, traditionally with newly diagnosed disease, combination chemotherapies are applied with the goal of achieving durable response. With relapsed disease, salvage chemotherapy, including novel agents, are attempted in order to achieve disease control and move on to additional salvage such as transplant. The frontline autologous transplantation has been a very active area of research, started with rather controversial data because of retrospective data sets, but now that we have more prospectively conducted clinical trials maturing, the view is that it seems to be more favored, and we would have more discussion just coming up shortly. The challenge, however, for management of T-cell lymphoma remains to be the difficulty to induce high quality and also durable response in a majority of patients. So the most common induction regimen is CHOP, and even though based on the peripheral T-cell lymphoma profiling project, there does not appear to be a survival benefit comparing anthracycline, which is CHOP-based therapy, versus non-anthracycline containing regimen. Other than the ALK-positive ALCL, which seems to have rather favorable outcome comparable to diffuse large B-cell lymphoma. So why are we still using CHOP, and what do we actually get with CHOP therapy? There have been numerous studies, I would say, over the years to study what's the outcome with CHOP. And here we basically summarized a few more recent study that was based on the WHO classification to make sure that we, in fact, have a unified definition of disease subtypes. And in those studies, which included the retrospective study from British Columbia Cancer Agency, the GILA group, as well as prospective studies from the German group and also the French group, that we know the frontline CHOP therapy essentially gives an overall response rate in the range of 60 to 80%, and that included a CR rate of 30 to 60%. The real question is the durability of response, obviously. So with long-term follow-up, especially for studies including patients that are essentially with chemotherapy alone, the durable remissions are only in the range of 20 to 30%, which remains to be rather very inadequate. So what has been experimented or explored in order to improve therapeutic outcome from the frontline settings? So a variety of strategy has been intervened, and they generally fall into the following category: adding ingredients into the CHOP backbone, or scramble and using alternative intensive regimen, and also to start prospective frontline stem cell transplant consolidation versus novel strategies. So in the interest of time, we really don't have luxury to kind of delve into the details of all those individual studies, but the message from those studies are rather simplistic, I would say uniform, in that simply adding ingredients, at least in the past, does not seem to translate any measurable benefit. One comment must be made to the addition of etoposide to CHOP based on the retrospective German data, which essentially pooled all the peripheral T-cell lymphoma subtypes from 7 studies, I believe, that showed an incremental event-free survival. However, those advantage seems to be limited to the ALK positive ALCL, but not much so in other peripheral T-cell lymphoma subtypes, which are the precise subtypes that would require an improved therapeutic index. And the summary from the super CHOP or non-CHOP type of frontline therapy, the conclusion is as following: that it may be possible to achieve incremental benefit by adding therapy to CHOP, and the benefit does not always seems to be equivalent in all subtypes. For example, we talked briefly about adding etoposide to CHOP, and very soon added toxicity or MTD side effects would outweigh the benefit. So at the very end, there's really not measurable outcome difference comparing more intensive regimen versus just CHOP-like backbone. So what about upfront autologous stem cell transplant? I do want to acknowledge Steve Horwitz from Sloan Memorial for providing this summary slides to me, that now that we have more maturing data from prospectively designed study that utilizing autologous stem cell transplant following induction chemotherapy, we do have a bit more data set to look through. So here, essentially summarize two published prospective data, one from the German study where CHOP was used as induction chemo, followed by moving on to transplant for chemosensitive disease patients who were eligible for transplant. The transplant rate was at 66%. The 3-year progression-free survival reported was at 36%. And the largest data sets came from the Nordic group, where the induction therapy was based on the CHOEP, which is addition of etoposide to CHOP, and either CHOEP 14 in younger patients or CHOEP 21 in elderly patients. Responsive patient would move on to transplant, and the transplant rate here was perhaps a little better, 72%, and the 5-year progression-free survival was reported at 44%. This was compared to the Sloan Kettering data, which is still in the process of maturing, which seems to be quite concordant, and they have a 4-year progression-free survival at 44%, and their induction treatment was a hybrid CHOP, either CHOP or CHOP ice, depending on really the quality of response based on the interim analysis. So one could argue that it's remained to be not ideal because you don't have a randomized comparator arm, but that may be very difficult to do in this patient population. So those remains to be our best efforts to date, and perhaps the largest data sets sort of put to date to support the notion that perhaps the frontline autologous stem cell transplant should be favorably considered, at least in patient who has chemo-responsive disease with intermediate or high-risk IPI score. And again, the last message from this transplant data set reinforced the idea that it by far, it's not a curative option, right, for a majority of patients. Now, relapse remains to be rather prevalent. And the next slide essentially summarizes sobering fact. And this is obviously not a new study, but a new published result from the British Columbia T-cell lymphoma registry, where they looked into over 150 non-transplant T-cell lymphoma patients who relapsed following their induction chemotherapy. So essentially panel 1, or for the entire cohorts who never went on to transplant, the median progression-free survival was only 3 months, and overall survival was less than 6 months. For more than half of those patients, they received some form of salvage chemotherapy, either single agent or combination, and I would assume those are modeled after B-cell type of salvage, that meaningful benefit was really not there. If you see that the median progression-free survival was just at 3.7 months, and overall survival was only 6.5 months. So really here, again, highlight the very much tremendous unmet need for getting better and novel therapy for peripheral T-cell lymphoma, and also makes one to rethink that a brand new, fundamentally different approach should be taken for this particular disease, other than traditional or conventional chemotherapy. So in the last 5 years, I would say there are at least 3 new compound biologics that have received FDA approval for management of peripheral T-cell lymphoma, with somewhat of a caveat. So as you can see here, we highlight pralatrexate, antimetabolite, antifolate, which was the first product to be approved for essentially generic peripheral T-cell lymphoma without specific subtype emphasis. And then this was followed by romidepsin, a type 1 HDAC inhibitor, which is also approved for peripheral T-cell lymphoma without a particular predilection to a certain subtypes. More recently, we have another biologics, which obviously works by a very different mechanism, the antibody-drug conjugates, Brentuximab, anti-CD30. And I probably don't need to go into details because you have heard quite a bit this morning regarding this particular compound. And that is to contrast with chemotherapy. traditional chemotherapy that was reported from retrospective clinical study, a mixture of chemo versus a more recent study on bendamustine, a renewed interest in an old compound. However, this particular study was conducted prospectively and in a relatively uniformly selected patient population. So we'll try to spend some time and make a few points here. The biologics, as you can see here, pralatrexate and romidepsin in particular seems to have moderate disease activity with a total response rate between 25 and 30%, and there is a fraction of patients, in fact, can go on to complete response. But the contrast to be drawn here is on its duration of response. For those lucky fraction of patients who somehow able to achieve response, the duration seems to be rather impressive compared with just chemotherapy treated patient, either in the retrospective registration data versus prospective phase 2 study. And therefore, overall survival was also better that compared to historical control. And with a more refined, I would say narrowly defined niche medication such as Brentuximab, we see even more impressive results, but keep in mind that it, for now, only applicable to CD30 target, the relapsed anaplastic large cell patient subtype, and 86% total response, 57% complete response rate, and duration response is over a year. Overall survival not reached. Chemotherapy, just to make a circle go around, remains to have significant role still for management of relapsed disease, in that the overall response rate, CR rate, remains to be rather respectable, over 50% total and 26% in terms of CR rate. But the key issue is that it's not a form of a durable, I would say, administration. You can't keep giving patients those type of chemo. And as you know, eventually they develop disease resistance and continue relapse. So it could conceivably be used as a bridge to something else, such as allogeneic bone marrow transplant in the relapse settings, or initial debulking followed by additional milder biologics for maintenance type of approach for someone who's not a transplant candidate. I also listed the single agent gemcitabine and also lenalidomide Revlimid, in the sense that gemcitabine has been widely used in clinical setting, but if you go back, look at the data, we don't really have a lot of survival data for that particular compound. And Revlimid, obviously, it's attractive in that it may have some kind of tumor microenvironment modulating ability, but we're really too early in terms of a study to have any meaningful conclusion. But one could also hypothesize that it may be attractive to be used as in combination with other type of biologics. So just dive a bit deeper into the HDAC inhibitors. I do want to mention this a new compound that are under intensive investigation, and in fact it just completed its pivotal study, which is the pan HDAC inhibitor belinostat. This is to contrast with approved romidepsin, which is a class 1 specific HDAC inhibitor. And here, both of them are IV, and the infusion schedule was a little different. It's once a day for 5 days in a row, but then patient has 2 weeks off and then cycles every 3 weeks. And interestingly, across the board, the total response rate was looking almost identical to romidepsin. If you break down into subtypes, which we were unable to do for romidepsin, for the belinostat, it seems that there may have some kind of increased signal activity in the angioimmunoblastic T-cell lymphoma. However, it's a relatively small sample size and it needs to be obviously sorted out. Additionally, the side effects profile also appears to be rather mild for the belinostat, which obviously lends support for consideration of subsequent combination, and we'll come back to that point. And then, given the really fairly impressive single-agent activity, Brentuximab, Vedotin, it's a very natural question to ask, could we extend the clinical utility of this particular compound to other type of T-cell lymphoma based on CD30 expression? Or at least that's what we think is the mechanism of action for Brentuximab, Vedotin. And I won't go through the details of this particular slides because you have already seen that, other than to say that it's antibody-drug conjugates, really depending on targeting CD30 molecules and allow dissociation of the attached toxin in a very directed cell-specific fashion. So there are a number of studies that has already addressed CD30 expression in all kinds of subtype of peripheral T-cell lymphoma. And this is just an example of which. This is one of the abstract from the recent Lugano conference, where they looked at close to 200 cases of PTCL from Western Europe. And the characterization was based on the immunohistochemical analysis plus messenger RNA evaluation as well. And in this particular study, and I want to apologize for rather faint numbers, that compared to the benchmark, which is ALCL staining, which tend to be uniform, if you make the cutoff at 5%, then rather impressive, about 60% cases of PTCL, angioimmunoblastic, HTLV1 associated ATLL would have CD30, qualify for CD30 expression. If you go with more stringent, about 20% cutoff, then you would have much less, but still with PTCL you would have about a third of cases, and HTLV, so to speak. So that really just lends a clinical feasibility of exploring this concept of can we extend this compound to other T-cell subtypes. And in fact, phase 2 study is ongoing. This is an update from the single-agent Brentuximab Vedotin in CD30 positive non-Hodgkin's lymphoma. As of this spring or summer, about 29 patients with PTCL have been enrolled. Amongst them, 11 patients had angioimmunoblastic T-cell lymphoma, 18 had PTCL NLS, and its expression range was 5 to 10%, sort of covers what we just talked about with those detection method, and its standard dose and treatment frequency, and about 22 evaluable patients. The bottom line is that the quality of response and also durability appears to be quite impressive. If you look at total patients, about 36% response rate, and particularly in the subtype of angioimmunoblastic T-cell lymphoma, about half of them. And then again, we only have 10 patients, so therefore. And this is quickly, we're coming towards the end of the discussion here, that there's essentially a very long list of potentially promising drugs, combinations that are being actively tested that fall into category of surface molecule antibodies, cell signaling kinase inhibitors, and also various combination of prior mentioned biologics. And obviously you're familiar with this asparaginase, which has been quite used quite a bit for extranodal NKT cell lymphoma. So based on the emergence of the availability of those new agents and also their activity, the paradigm of T-cell lymphoma treatment is continuing to evolve in the sense where novel agents are now increasingly being moved to the frontline settings, and patients and physicians should be encouraged to participate in clinical trials. And this would accelerate our product development in general. And just to give example also, just for your information, that from a frontline standpoint, there are a variety of combinations that are being rolling out and available, enrolling. And one of the option was just adding the newer agents to a CHOP-like backbone and doing a randomized fashion to compare with CHOP only. Those availability, including the Brentuximab, addition to CHOP without vincristine and compared to CHOP alone, those are for CD30 positive T-cell lymphoma. It's actively accruing right now. Romidepsin combination with CHOP to compare to CHOP alone, those are being done led by the French GILA group. I believe the dose finding portion is already over now into the efficacy enrollment. And as we mentioned earlier, belinostat, which has rather mild myelosuppression now, it's also being combined with CHOP to compare with single arm with CHOP only. And the other strategy is to extend the durability after chemotherapy induction, and those would include maintenance strategy given the essentially durability of some of those biological compounds. So in non-transplant patient candidate, there's a randomized study of adding pralatrexate following induction CHOP. And then for those who are transplant candidates, obviously prospectively designed clinical trial with autologous stem cell transplant consolidation should be highly considered. And there's also additional maintenance option with romidepsin in this one particular study as listed here. So just to conclude, that certainly we now have a lot of newer options which certainly present a lot of renewed opportunity, although challenges remain. So in the frontline settings, we now all agree that CHOP is inadequate for most, but finding something better than CHOP is not that easy. And then standard of care should really be clinical trial whenever possible, that oncologists and patients should really highly consider recruitment for clinical study, and strategy of adding a new drug to CHOP is being actively explored, and could we also, in some instances for certain subtypes, to move away from combination chemo altogether. And lastly, consolidation, high-dose therapy versus maintenance strategy following chemotherapy. In relapse settings, we touched upon how to prioritize chemotherapy versus biologics, the pros, cons, what's the data on their response rate, and also duration of response. And is there an algorithm to cycle through various biologics? And I think the answer is that we need more data from translational biology standpoint to know exactly what's the mechanism of action for all those biologics, and also more data on just comparing arm to arm as to what are the difference and similarity between those biologics. And finally, transplant versus maintenance following salvage. I think the fact that we're able to discuss the concept of maintenance is a step forward compared with just salvage chemotherapy, because we do have some of those biologics that are becoming available and could be potentially considered in that particular light. So lastly, I want to just mention and acknowledge my colleagues at Cornell and also Steve Horwitz for lots of helpful discussions. Thank you very much.